Hello, everybody, and you are very warmly welcome to this MedOll educational program. This is the first time you're joining a MedOll program, and you're especially welcome. MedOll exists to make medical education radically accessible to every colleague everywhere, no matter where they are, always free and always open access. We hope you find today's CME session really useful for your practice. My name is Dr. Petros Grivas, and I'm a medical oncologist here in Seattle. I'm a professor at the University of Washington School of Medicine, and also I'm serving as Director of International Program Local Regional Outreach here at Ferhat's Cancer Center. I'm also a professor at Ferhat's, and it's my distinct honor and pleasure to be joined today by esteemed colleague and friend, Dr. Ben Garmezy, who is a medical oncologist and the Assistant Director of Genitourinary Research for Sarah Cannon Research Institute at the Sarah Cannon Research Institute Oncology Program and Oncology Partners. He's specializing in advanced therapies and clinical trials for GU cancers, prostate, kidney, and bladder cancer. Before we begin, it's important that we share our disclosures with you, and these are disclosures for consulting, research funding, etc., and you will find that in that slide. Now, I want to focus your attention on the learning objectives for today's sessions, including how we can interpret key diagnostic and prognostic biomarkers, including pathology, imaging, and clinical risk factors to support risk assessment at diverse care settings. We also want to, after completing this important activity, to see if we're able to apply diagnostic findings to determine when to escalate care, refer, or adjust treatment planning based on available local resources. We also want to design and implement guideline-aligned treatment pathways for high-risk, non-muscle invasive, muscle-invasive bladder cancer, and metastatic urothelial carcinoma, accounting for workflow and access challenges in community and rural practice settings. Last but not least, another objective is to implement practical strategies to navigate resource limitations and strengthen care coordination to support consistent bladder cancer management. We would like to have some polls in today's session, so you will be able to answer those questions using the chat on the right side of the screen or using the chat icon on your mobile phone. If you place the video in full screen, you will need to exit full screen video to answer the polls. We also have some time for questions and answers at the end, so please put any questions you have in the chat box. That will be very helpful, and Dr. Garmezy and me will be very happy to answer those questions. With that, we're going to embark and start our first discussion point today, which is about non-muscle invasive bladder cancer. And I'm going to start by discussing some details, and I'm going to also, of course, let Dr. Garmezy take it from there. I want to start by setting the stage and putting the framework about non-muscle invasive bladder cancer. Many patients call it more superficial than the more deeper muscle invasive bladder cancer, and that's an important distinction with significant differences in terms of diagnostic stage and management, and of course prognosis. And so in this risk stratification slide, we see how we stratify the risk for non-muscle invasive bladder cancer in terms of low, intermediate, and high risk, and there are certain criteria. Our colleagues and friends in urology are those who actually make this diagnosis, manage those patients in the most part, and they can stratify the risk based on the grade of disease, based on the size of the tumor, focality, and recurrence pattern, presence of carcinoma in situ, left vascular invasion, histology subtype. All those factors can play in the risk stratification for this cancer. And if we move across, the different risk factors here, the management is also different. So that slide is complicated, but just to give you a flavor that low risk, intermediate risk, and high risk non-muscle invasive bladder cancer are being managed differently. And of course, if we think about how can we risk stratify even further, we have criteria from the International Bladder Cancer Group, for example, looking at the number of tumors, the time of recurrence, less than a year from diagnosis, the frequency of recurrence, if it's more than one recurrence per year, the tumor size, if it's more than 3 centimeters, or failure of prior intravesical treatment, or those are negative prognostic factors and can influence, again, risk stratification and management. And you see in the lower part of the slide what are the different management options in patients with no extra risk factor, 1 to 2 risk factors, or 3 or higher risk factors. Again, just to give you a flavor, and I want to say that PURBT, transurethral bladder tumor resection, is so important in the diagnosis, in staging, and of course, insights into the histology subtype, presence or not, whether it's carcinoma in situ, left vascular invasion. So very important to have tissue in that decision-making for therapy. And of course, again, as I mentioned, risk stratification and prognosis. Of course, recurrence and progression are the main concerns when we have non-muscle invasive bladder cancer. And you see the risk of recurrence and progression, of course, depends on the grade and the stage of the tumor. Grade is low grade or high grade. High grade is, of course, has higher risk of recurrence and progression. And the stage, of non-muscle invasive bladder cancer is at CIS, carcinoma in situ, only TA, which is a non-invasive papillary tumor, or T1, which means papillary tumor invading the lamina propria, but not the muscularis propria. It's not muscle invasive. And of course, if you have a higher stage, like T1, you have a higher chance of recurrence and progression. You see that there is a chance of further progression to muscle invasive disease. For example, 50% within 3 years if you have a T1 tumor to go to T2. So again, it's important to have the stage and the grade, and of course all the other risk factors assessed. And I think it's important to know that carcinoma in situ is CIS is by definition a high risk feature, along with left vascular invasion and the presence of histology variants or subtypes. I want to also point out that it's very common practice, and I'll show a slide in a second, that when you have a T1 and sometimes a high-grade TA, you need to re-resect again to make sure you're not missing a T2, a muscle-invasive tumor component. Recurrence and progression, again, depends on multiple factors, focality, number of prior recurrences, the size of the tumor, the grade, carcinoma in situ presence or not, and again, all those factors to a different degree may influence the risk of recurrence and progression. What can we do about this? Of course, the urologists are experts and they want to optimize cystoscopy, and that's important because now we have enhanced cystoscopy, narrowband imaging, blue light are some examples of that. Of course, we need to get the staging right. So accurate staging is important. So high quality URBT, which is transurethral bladder tumor resection, is very important. And now we're starting to see incorporation of clinical useful biomarkers as we get more data and better technology. We're using more biomarkers in clinical practice in that regard. And of course, the other goal is to identify failures early and offer radical cystectomy with pelvic lymph node dissection when indicated. So I just mentioned that our colleagues in urology mentioned that quality of TURBT matters. So it's very important to have an experienced urologist who has done many TURBTs. I think it's important to have an optimal resection of the tumor. Sometimes they have, again, different techniques. And of course, the goal is to, depending on the setting and whether it's feasible or not, to remove the entire tumor if it's possible, of course, as I mentioned, especially if there is plan for bladder preservation down the road. And again, the technique matters, quality matters, and the experience matters. I talked about resection. As I mentioned, if you have a high-grade T1 and sometimes TA, urologists resect because you do not want to miss a T2, a muscle-invasive component. Very important in terms of resection because you may actually understage, even if you do not think it's T2. Sometimes it may be a T2 stage nearby. And if you have muscularis propria in the specimen of the TURBT, there is about 20% chance of understaging. And also, if you miss or if you lack muscularis propria in the TURBT specimen, that actually can increase the risk of understaging to up to 50%. So again, resection is very important in that setting. So I want to also make the point here about urinary biomarkers, that there are many that are under clinical trial testing. And of course, the goal is to improve upon cystoscopy and urine cytology. Urine cytology can detect a high-grade urothelial carcinoma, but it's not very sensitive, can miss more than 20% of high-grade disease. And as I mentioned before, urine cytology is not a good test for low-grade disease. So it's important, again, to have an improvement in that regard through novel biomarkers. And of course, this is urine cytology, takes some time to go through the preparation and pathology review. So it's not a point of care test. And this is a snapshot from the AUA, American Urological Association guidelines. This is urine biomarkers after diagnosis of bladder cancer. This is just to see that a lot of expert opinion here. That tells us that we still need more data. We need more trials to give us more data points about clinical utility. And in surveillance of non-muscle invasive bladder cancer, a clinician should not use urinary biomarkers in place of cystoscopy. Cystoscopy still has a major role. There are scenarios where you can potentially do cystoscopy less frequently and use urinary biomarkers in specific clinical scenarios based on available data. These are just some of examples of urinary biomarkers, and here specifically biomarkers that seem to be approved. You see here on the left the name of the biomarker, and then the performance characteristics on the right, sensitivity and specificity. Of course, those performance characteristics can vary per assay and, of course, per study. There are other promising biomarkers not approved yet, but interesting for the future. You see here some DNA-based, RNA-based, and protein-based. I just want to give some highlight here about the performance characteristics. As I mentioned, a lot of data are coming up soon, exploring those DNA, RNA, and protein-based biomarkers in a plethora of clinical trials. What about the practical scenario if cystoscopy is normal, but urine cytology is not normal? Of course, we have to think about upper tract disease, very important, to make sure there's no hiding upper tract tumor in the kidney, pelvis, or the ureter. Of course, sometimes cancer may be missed on cystoscopy, even with experienced hands and eyes. For example, carcinoma in situ sometimes can be missed. Blue light could potentially help in certain scenarios with that. Prostatic urethra is a common area where you may have some cancer arising from there, and is not part of the bladder, but is further distally. So prostatic urethra evaluation is very important. We talk about blue light and carcinoma in situ evaluation and, as a more sensitive technique based on some data. Of course, if you have a high-grade cytology positive or suspicious, usually you follow with a TURBT. When you have atypical cytology, usually this does not change management. The atypical, of course, we need more biomarker to refine this risk. This is a list of FDA-approved intravesical therapies over the years, just for the audience to take a look. Of course, things are moving faster now compared to the last 4 or 5 decades. And here is a slide that shows some recent, very important data for BCG-naive high-risk non-muscle invasive disease. As we all know, intravesical BCG is the standard of care for patients with BCG-naive high-risk non-muscle invasive bladder cancer. Just recently, literally a couple of weeks ago, we saw an FDA approval of durvalumab, an intravenous anti-PD-L1 agent, a systemically administered checkpoint inhibitor that is given together in conjunction with intravesical BCG. That's a Potomac trial that I put here in that slide, and I put a yellow box because that Potomac trial resulted in the FDA approval of durvalumab. The big question here is which patients may benefit more from having durvalumab addition and intravenously, in addition to intravesical BCG, and of course, what will be the uptake in clinical practice, because of course, there is a significant risk reduction in terms of high risk recurrence or high grade recurrence. However, at the same time, there could be a potential risk of immune-related adverse events with a systemically administered checkpoint inhibitor. So I think we still have to define patients who may benefit from this, but something important to note here, to think about the recent FDA approval of durvalumab, again, based on the Potomac trial in BCG-naive high-risk non-muscle invasive bladder cancer. And I put the other trials for context, CREST and ALBAN trials, because all of those trials have been reported recently as well. And a few words about the BCG terminology, a lot of discussion about what is BCG refractory, relapsing, intolerant, and unresponsive. I think these definitions are very important. First one, for clinical practice, and secondly, because they define eligibility in clinical trials. So I think it's very important to be familiar with these terminologies and definitions and help understand exactly the criteria, because as I mentioned, this has major implications on how we define its disease space and therapy setting. This can have implications of what treatments a patient may be eligible for, and of course define, as I mentioned, endpoints and eligibility criteria for clinical trials. And here, a little bit more word about BCG unresponsive non-muscle invasive bladder cancer based on expert opinion. You see here definitions in that slide. This has been a lot of work with FDA, the International Bladder Cancer Group, and of course, multiple experts with consensus. You see here high-grade T1 at first evaluation following induction BCG. That's BCG unresponsive. If you have a persistent or recurrent high-grade TA or T1 within 6 months of an adequate BCG course, or persistent recurrent CIS within 12 months of an adequate BCG course. Adequate BCG course is defined of at least 5 out of 6 induction doses, plus I think it's 2 out of 3 maintenance doses, or if you have at least 2 more doses in induction course. So again, variable definitions are being described in this slide, in the previous slides. But I think that how do you define adequate BCG course is important, again, for clinical practice and trial eligibility. And this is a very interesting slide showing a number of recently FDA-approved agents for BCG unresponsive high-risk non-muscle invasive bladder cancer. You see here an intravenous pembrolizumab is the only systemically administered agent. The other agents are intravesical. As I mentioned, radical cystectomy lymph node dissection is still very important and maybe the right answer for many patients. And of course, clinical trials, always something to keep in mind. Here's a slide about ongoing trials. It's not to be memorized, but just to give you a flavor of how many trials are going on in non-muscle invasive bladder cancer. It's very exciting, a lot of work, and stay tuned for more data results and clinical trial updates in the future. Cost is a very important component, and many of those agents are very expensive. So access to care, reimbursement, not only in the US, but also outside US is important. But also within US, I think the cost of care is a very important component. I want to make sure we're mindful of that. And I know many centers and institutions are looking into this and having discussion about, what can be offered and what can be available and what can be sustained in terms of healthcare burden and cost. So something important to keep in mind. Of course, we want to give the best treatment for the patients, but many of those trials that led to the approval of those agents were not randomized, and I think that's another relevant point. The CISTO study by my colleague, Dr. John Gore, here at the University of Washington for Heart Cancer Center. Interesting study. It was a pragmatic study, not a randomized trial, because it was very difficult to do a randomized trial in this setting. Previous attempts failed to do a randomized study. So CISTO was a pragmatic study that evaluated patients who had bladder preservation or radical cystectomy for BCG unresponsive non-muscle invasive bladder cancer. And what you see here, some key results that were published recently at Journal of Clinical Oncology by Dr. Gore and his team. And you see it's interesting that in some domains, in terms of quality of life, like physical functioning, global health function, and the EQ5D domain, there's a trend towards favoring radical cystectomy. Of course, there are many nuanced data sets in this study, and I welcome all of you to look at the paper at JCO to look at different things, and you can different domains, how they differ between patients who opted for bladder preservation or radical cystectomy. And you see on the right lower corner that, for example, bowel health, sexual health, and progression-free survival in that particular study, for whatever reason, favored bladder preservation. On the right side, physical functioning, cognitive functioning, mental health, financial health, recurrence-free survival, favored radical cystectomy. Again, it's an interesting study to look at. And this is the last slide in this non-muscle invasive bladder cancer section. New intravesical therapies and, of course, systemic therapies like checkpoint inhibitors are expanding our options and choices. Our job is to convey the data sets and discussion with the patient, the individual patient level, and help them make informed shared decisions that they feel comfortable with. Of course, one size does not fit all, so it's important to individualize as much as possible based on the available data sets and patient comorbidities, performance status, preferences, and other factors in the clinical practice in the as much as possible personalized manner. Intravesical BCG plus minus intravenous durvalumab is now the standard of care for BCG naive high-risk non-muscle invasive bladder cancer. I mentioned plus minus because, as I mentioned, durvalumab was just approved in this setting very recently. The question is which patients may benefit from that, and which patients are going to receive it based on the urology and medical oncology discussion with the patient. Future approaches will likely be risk adapted, biomarker driven. And again, the question is how do we integrate systemic immunotherapy in this setting of non-muscle invasive disease? Patient preferences are important. Access to therapy is something that we discussed, along with financial toxicity. And of course, decision-making is important based on optimal patient education. We need to measure toxicity, patient report outcomes using proper valid instruments, and there's work being done in that domain. And of course, clinical trials is always the key, how we make progress. And of course, our goal is to improve outcomes. With that, I want to thank you for the attention and pass the baton to my dear colleague, Dr. Ben Garmezy, who's going to give us his important insights. Thank you.
Hello, good evening. My name is Ben Garmezy, and I'd like to thank Dr. Grivas for that initial presentation and welcome. Now I'm going to be talking about the high-risk non-muscle invasive bladder cancer treatment escalation details, but I'm going to give it to you more from a community perspective, which is a little bit different from where some of us practice. First case, we'll be discussing navigating high-risk NMIBC in a rural setting. So this is a 68-year-old male who presents with gross hematuria and lower urinary tract symptoms. He has initial transurethral resection of the bladder tumor and performed at a local rural community hospital. And the pathology report indicates a high-grade papillary urothelial carcinoma. And the report lacks detail on the presence of any detrusor muscle presence, variant histology, or lymphovascular invasion. The nearest subspecialty urologic oncologist is about 2.5 hours away, and the local clinic has limited operating room time for a prompt repeat TURBT, and there's an ongoing local shortage of BCG. So a poll for you today: when faced with a non-granular pathology report and limited local operating room availability, what is your primary clinical priority for this patient? You can see the 4 options below. All right, thank you for those answers. So now to kind of shift gears, right? What are the real world challenges that many of us, medical oncologists, urologists, even radiation oncologists, face that are different than those colleagues that are practicing either in these large academic centers or these large hospitals where there's all that multidisciplinary input within the same roof, right? So one, the pathology. Is that detailed GU focused, or is that general pathology review? That's not to knock our general pathologists. They have a really hard job of having to stay on top of everything. But sometimes those details, when we look in the guidelines, aren't always there for us to actually follow the guidelines if that review doesn't have that full kind of detailed report. The other thing we think about is most of the data that is presented in all the clinical trials are indicated based off of a maximal TURBT. Many times our patients are getting diagnostic TURBT, which means that urologist goes in for hematuria or whatever those symptoms that prompted that intervention were. That urologist then does a quick TURBT, gets a path answer, finds out that it's malignant, but we didn't do a complete transurethral resection. So I think that's critical if we're going to especially move into bladder sparing and some of these other techniques. A maximal TURBT has a complete response rate in and of itself and probably can cure a subset of patients, but also it helps us further improve upon outcomes, even in patients that need systemic therapies and more definitive therapies, because there's less cancer there to begin with. The next thing is, our actual diagnostic workup. Not every clinic has blue light visualization. Not even all of our academic centers have that, but we know that blue light visualization is a helpful tool to really understand the extent and the scope of the cancer, especially in non-muscle invasive bladder cancer, where we can see better patches of CIS, T1 papillary disease, that maybe traditional light and our eye sometimes miss. Going back to that kind of repeat TURBT, and this was alluded to in the question we had, many times in these diagnostic TURs, we don't have a muscularis propria in the sample, which means we don't know if this tumor is muscle invasive or not. We might have hypothesis based on what our urologist saw during that cystoscopy, but unless we truly have muscle sample and they scrape deep enough to get that muscle, we really don't have a full diagnosis, and we really don't know what the right treatment is for that man or woman in front of us in clinic. Now, of course, the mainstay of non-muscle invasive bladder cancer treatment is with BCG. We know that right now there's a BCG shortage. It takes longer to get it, and it's harder to get it. So this might lead to delays in care. And we also understand that some of our community clinics that we work with don't always have that BCG stock in sight. So another thing to think about when navigating what therapy selection we should give intravesically for our patients with non-muscle invasive bladder cancer. In addition, if we're not going to give BCG, do we have a mixing hood? Can we give intravesical chemotherapy? Can we give some of these other options with our community urology-based partners, or how can we work with local community hospitals to provide access to that care? Because to give intravesical chemotherapy requires pharmacist and mixing, right? So these are things that also sometimes we don't think about. We can't just follow, okay, this is step 2 in the algorithm for the NCCN or the AUA guidelines. Actually, no, can we actually even deliver this therapy? And that's always step 1. And then biomarker access. Right now, biomarker access is an evolving paradigm in the treatment of urothelial cancer. Obviously, ctDNA has made quite a big splash. Urinary DNA is now moving into this space quite rapidly. Probably in the very near future, we'll have some more treatment decisions in NMIBC based on these algorithms. There's already a FDA approval using ctDNA in muscle invasive bladder cancer after cystectomy. If those patients are ctDNA positive, the addition of PD-L1 inhibitor atezolizumab can be given. That's based on the IMvigor011 study. So biomarkers are rapidly moving to the space, and there's a heterogeneous uptake and availability of those products that we can offer our patients for better prognostic and perhaps predictive in the future indications. So digging more into pathology, as I mentioned, do we know if the sample is truly non-muscle invasive or muscle invasive? And what's the extent of that invasion? Obviously, the extent of that invasion can give us more clues on which patients, when navigating a comorbid situation where maybe our systemic therapies would provide more harm than good, understanding what the actual risk to that patient is in front of us. Now, we're going to be focusing on non-muscle invasive bladder cancer for the rest of this talk. But remember, we don't truly know if they're non-muscle invasive unless we have a good sample. So I think that's always key. And then the extent of variant histology, I think, is also important. Not just the presence, which is sometimes we get on local pathology reports, binary yes, no, is this urothelial mixed with squamous or mixed with neuroendocrine or mixed with one of these other plasmacytoid, et cetera. We actually want to know the relative percentages. That's really going to also help us understand the prognosis, but also therapy selection for that patient in front of us. And of course, the extent of carcinoma in situ, also critical, something that we don't always get unless we ask for it. So what are the concerns, right? Understaging, obviously, alluded to that many times. Difficulty assessing the risk of that patient in front of you so that you can pick the right treatment and understand the side effect profile. It's always about informed consent, right? What's the relative risk and benefit for that person in front of us? Not to mention then also if we have to repeat path or resend the pathology out, that can take a couple weeks. And then there's delays in referrals, delays in intravesical therapy. And do we risk a patient that could have been treated with less harmful, less invasive therapies now requiring more invasive or more toxic therapies due to those delays in therapy? So that's always something that we want to keep in mind. So when should we potentially refer that patient in front of us? Well, it's up to your comfort level, right? We're speaking to you. You're a medical oncologist or a urologist or a radiation oncologist maybe, or a practice provider. If you're comfortable and experienced, that's great. But when do you want to start thinking about in non-muscle invasive bladder cancer that you might need a urologic oncologist? High-grade T1, obviously something we think about. These patients have historically been considered for cystectomy. Of course, now we have a lot of intravesical options that we can try carefully first. Variant histology, how well are those intravesical options going to work? They're going to work differently in patients with variant histology. We're also going to want to know what that variant histology is, because that's going to also indicate how well those treatment paradigms might work. Recurrent high-risk non-muscle invasive bladder cancer, maybe we tried something first and the cancer's coming back. Again, I like to call this, we can play for a little bit. We can continue therapies to try to spare that bladder for a little bit. But at some point, we do risk the metastatic spread, which historically has been viewed as an incurable illness. So we want to be careful and make sure that at some point we provide a definitive therapy, whether that be cystectomy or chemoradiation, for that patient in front of us if we keep running into recurrent high-risk disease. And remember, If you really feel like you need it, go ahead, refer for a repeat TURBT so that we make sure we have the adequate diagnosis. And remember, maybe that urologist can go back and do it. You just need to ask. You might not need to refer that out if that urologist is capable. Sometimes it's as simple as picking up the phone and saying, look, can we go back in the next 1 or 2 weeks to really assess this patient in front of me? So that's all those questions, but the why is important. What's the treatment escalation? And we've seen now a lot of talk about how do we move immune checkpoint inhibition into earlier lines of therapy, including in non-muscle invasive disease. And you can see there were 3 studies recently presented over the last year or two. One of those studies was negative with atezolizumab plus BCG versus BCG. One of them was with sasanlimab, a subcutaneous injection of a PD-1 inhibitor. That was positive, but not going forward for a label at this point. And then we had Potomac, which was durvalumab, a PD-L1 inhibitor plus BCG in that high-risk, non-muscle invasive BCG naive population. And now that recently has been FDA approved in the last month. So adding checkpoint inhibitors is an emergent strategy in high-risk disease, but we need to interpret this data in the context of potentially lifelong systemic side effects. So that's the why here. So this is Potomac. I'm not going to talk to you about all of these studies. We're going to focus on the study that just led to the FDA label. And there were actually 3 components randomizing over 1,000 patients to durvalumab plus BCG, induction and maintenance. And I put an exclamation point next to the M because the maintenance is critical. Durvalumab plus BCG alone without the maintenance is the induction, and then BCG alone with the induction and maintenance. And the key here is that, overall, wait first before we get to the key, balanced disease, about 2/3 papillary, high risk in about half of patients. So a nice evenly matched sample. And here's the disease-free survival. And we're not going to show you just the induction arm. The key is the induction and maintenance of BCG, that black arm. Yes, it's lower than the durvalumab plus BCG arm, but it looks pretty darn good too, right? So at 36 months, the probability of disease-free survival is 77% with BCG induction and maintenance, and 82% with the addition of durvalumab. So we're basically at 36 months adding 5 percentage points to that kind of landmark disease-free survival. Hazard ratio very clear, 0.68. P-value very statistically significant. Curves separate. There's no issues with this Kaplan-Meier curve, right? And of course, this data is not fully mature. This was data presented at ESMO in 2025. So what I'll say is the highlights here is the induction and maintenance BCG performs quite well, and durvalumab does add some efficacy here. Now, this was presented at ASCO 2026, really just a few weeks ago. And what they're showing is the overall survival is very similar. About 2 percentage point difference at 5 years. That's 60-month landmark. Hazard ratio not statistically significant is 0.81, but it's trending in the right direction. And I think that that's also important. Getting overall survival in this disease state is always going to be complicated. This is non-muscle invasive disease. These patients will get subsequent therapies. They might get cystectomies. They might get other things. And of course, this disease is less lethal than the muscle invasive counterpart. Now, they also presented the quality of life indicators, right? And you can see here, when you add in durvalumab, there's a little bit more fatigue. Physical functioning is a little bit worse, right? But they're all relatively similar. Urinary symptoms, similar. So sexual functioning, similar. Overall, when you look at this, quality of life really not, on average, harmed too much based on the addition of immunotherapy. And you can see the tornado plot of the side effects in the bottom right hand of this slide. Very few grade 3 or greater adverse events, very evenly balanced, a little bit more hypothyroidism, clearly with the immunotherapy. That's not a surprise. But overall, when you look at that adverse event profile, pretty balanced. Now, however, what doesn't get captured on these types of average quality of life indicating metrics and an average tornado plot is the context of what we know from immune checkpoint inhibition, roughly about 10% life-altering toxicity rate. And maybe that's just, I need thyroid supplementation the rest of my life. But it could mean you need insulin for bad pancreatitis induced by the checkpoint inhibitors. It could mean many things, lifelong immune suppression for bad colitis, or maybe you're on 3 months of immunotherapy and developed an infection from immune suppression. So we have to put the context of that relative 5% improvement at that sort of 36-month landmark DFS relative to the side effect profile. So this is a good option for patients, but it needs to be interpreted carefully, and probably not every high-risk non-muscle invasive bladder cancer patient should get durvalumab plus BCG. It's an option for those most at risk. Now, when we look at other intravesical options, such as the Terrace 200, this is the Terrace platform. It's what we used colloquially call the pretzel. It's this plastic tubing that kind of involutes on itself and makes that shape like a pretzel. It's about the size of a coin. And what it does is it slowly releases gemcitabine over a longer time. This is a new agent that's approved after BCG in patients that have recurrent NMIBC. You can see the complete response rates are quite high, 82%. Durability, about 53% at 12 months. So there are still a lot of patients that are going to need to either get more therapies or definitive resection or radiation after this as well. But it is a good option for patients who really want to maintain their bladder function as best they can for as long as they can. Now, I'm not going to go into everything because that was just the most recently FDA approved, but let's talk about other things. Let's first benchmark against pembrolizumab. This is a PD-1 inhibitor, systemic drug, 41% complete response rate, about 50% at 12 months. And you can see about 50% at 12 months is a theme throughout these. There's other intravesical interleukin and cytokine-based therapies. That's natafaragine and novopendican. You can see here relatively high CR rates, but again, losing some of that kind of sustained response at 12 months. These are very, very small data sets, and therefore we need to be interpreted cautiously and not do direct comparisons. But intravesical gemcitabine and docetaxel is one that maybe is a little less flashy, but has similar 12-month, can sustain CR rates and, very high CR rates in some of these earlier studies. Now, CRs are complicated because it's based on how the cystoscopies were conducted on the trial, how rigorous the requirements were. Did they require mapping? Did they require blind biopsies? All these things are different across these trials. So we really shouldn't be comparing these numbers, even though I love to do cross-trial comparisons in other data sets. I think these ones we really have to be cautious about that. My whole point is there's activity, and we can provide some of these newer agents with caution in the right patient selection. So with that, how does a real-world, community-based, non-muscle invasive bladder cancer algorithm go? It's one, you got to ensure a high-quality TURBT. And if high risk, consider BCG. If it's unavailable due to the shortage, can you get them to a place that can give gemcitabine or docetaxel intravesically? Some local hospitals can do it, not all can. And really, we need to be referring these patients out if we can't provide these therapies. Of course, we also have the option to refer for those novel therapies that are not available at most clinics across the country at this point. They're very expensive, and you run the risk of some severe financial toxicity as well, not just for the patient, but for the clinic if it's not billed appropriately. And then, of course, if refractory to the first therapy, we can consider these novel therapies, but then we also need to start thinking about resection or chemoradiation for these patients in front of us. Now, there's still a lot of remaining questions, and I think maybe we'll dive into some of these in the discussion later tonight. But who should get durvalumab in addition to BCG? Who still needs an early cystectomy instead of maybe giving a trial of BCG or some of these other intravesical agents? How do we prevent overtreatment? That's providing, say, checkpoint inhibition into patients that don't all need it. How are we going to use biomarkers like ctDNA and uDNA in the future to really determine who should get what care, as well as how do we expand access to some of these programs? And then how do we get these newer intravesical drugs out into all the community clinics closer to where the patients are in their homes? And how do we get the experience to some of these physicians in those regions as well that may not have given these agents?
Now let's turn our attention to muscle-invasive bladder cancer. After we discuss the non-muscle-invasive disease state, let's talk about muscle-invasive disease. This has important implications, as I mentioned, for treatment and prognosis. And the impetus to give neoadjuvant cisplatin-based chemotherapy over the years as standard of care for many years in this disease of muscle-invasive bladder cancer has been mainly because we aim to eradicate microscopic metastasis, micrometastasis, which actually represents the lethal phenotype of the disease. And I think that's important because patients think about what they see, like the bladder cancer, the bladder tumor. At the same time, I share with the patients that I'm also worried about what they and we may not be able to see, and that's its potential presence of micrometastasis. So that's a main reason we give neoadjuvant systemic cisplatin-based chemotherapy over the years. And of course, this is important because it allows patients to at least go after potential presence of micrometastasis while it's preserving the option of doing radical surgery, and patients are getting radical surgery after neoadjuvant systemic therapy. They do not need to recover, right, after surgery. For example, the adjuvant setting, after radical surgery, you have to recover, right, from radical surgery, and you do the systemic therapy before, you do not need to have that recovery component. Again, neoadjuvant versus adjuvant, although I'm going to show you data that actually both phases seem important, both neoadjuvant, adjuvant, this perioperative therapy setting, and I will go to show you some important data in a second. I'm going to start with the Niagara phase 3 trial, and as I just mentioned a second ago, we live in the era of perioperative trials. So management is based on neoadjuvant and adjuvant setting. You see here Niagara trial includes patients with muscle-invasive bladder cancer, localized, resectable. The comparator is the neoadjuvant GEM-CIS chemotherapy with no planned adjuvant treatment. The experimental arm is the addition of durvalumab, anti-PD-L1, in patients who are fit for cisplatin, of course, 4 cycles of GEM-CIS durvalumab or GEM-CIS neoadjuvantly, radical surgery, and then in the experimental arm, there were up to 8 monthly doses of durvalumab in those patients who could tolerate it, of course, and dual primary endpoints, event-free survival, pathological complete response rate, with overall survival being a key secondary endpoint. You see here the stratification factors. You see how the event-free survival was defined in the right lower corner. Interestingly, patients who selected to not have radical cystectomy, if they choose to not undergo surgery, this actually was counted as an event in the study as per regulatory guidance, so something to keep in mind. Event-free survival, significant improvement. Hazard ratio overall was 0.68 in the intent to treat population. And if you break it down, the benefit seems to be present in patients with and without pathological complete response. So patients who achieved path CR and patients who did not achieve path CR, both of those patient subsets appear to derive benefit from durvalumab, again, given perioperatively pre and post radical surgery. And you see the hazard ratios in those subsets. Same story here with overall survival that was also met. The durvalumab addition perioperatively resulted in improved overall survival. Hazard ratio 0.75 in all comers, intent to treat population. And you see here the breakdown. Of course, these are underpowered exploratory analysis, you can argue in a way, because the number of events are small. But what you see there that the hazard ratios 0.72 and 0.84 are in the right direction for both patients with and without path CR in terms of the perioperative durvalumab addition. Of course, because of the low number of events, again, these are immature follow-up in the subsets. But as I mentioned, the trend is in the same direction with the overall population. And in the overall population, there was conclusive benefit for overall survival with perioperative durvalumab. These are toxicities, and of course, there's no surprise. We know across cancer types that if you add cisplatin, gemcitabine, and checkpoint inhibition, you may have the risk of immune-related adverse events from the durvalumab. However, if you see the slide, and we saw in publication and different data sets across conferences, the toxicity profile is consistent with what we expect with chemotherapy alone, and the combination seems feasible and manageable. Of course, extra education is needed, but the combination seems to be feasible. And the important point is that patients who go durvalumab were able to undergo radical surgery to a similar rate, similar degree, compared to the GEM-CIS neoadjuvant alone. For example, 88% of patients underwent radical surgery with GEM-CIS durvalumab, and 82% or so with GEM-CIS alone, so 83%. So overall, the numbers look very similar in terms of the proportion of patients who underwent radical surgery. So in other words, the addition of durvalumab neoadjuvantly did not compromise the ability of patients to undergo curative intent radical surgery. So this is the summary of what I discussed so far for the Niagara trial. GEM-CIS plus durvalumab is FDA approved as perioperative regimen, GEM-CIS durvalumab neoadjuvantly, and durvalumab alone as adjuvant therapy up to 8 monthly doses in patients, of course, who can tolerate it, and the majority of patients can tolerate the durvalumab. The toxicities as expected with no new safety signals. And as I mentioned, that's a therapy option in the perioperative space face localized muscle-invasive bladder cancer for cisplatin-eligible patients. Of course, there are multiple ongoing clinical trials that looks, I think, in the future, and all these trials are going to shape and keep reshaping the landscape. I think if we look at the left upper corner, we have the Niagara trial. We're waiting for the Gemcis pembrolizumab. There was a press release that showed that the Gemcis plus minus pembro did not meet the primary endpoint. We have to see the data, of course. Gemcis plus minus nivolumab is pending on the right, and enfortumab vedotin trials. I want to make the point that the Volga trial is going to be reported in the near future. That's a positive trial. It seems that durvalumab plus enfortumab vedotin neoadjuvantly followed by radical surgery followed by durvalumab adjuvantly seems to be prolonging overall survival and event-free survival compared to no perioperative therapy in cisplatin ineligible patients. We're waiting the data from Volga. I'm going to show you data about Keynote B15 and Keynote 905. In the left lower corner, we have the modern trial is ongoing. It's a purely adjuvant trial based on ctDNA, asking an escalation and the de-escalation question. And the right lower corner is IMvigor011 that was presented by Professor Pauls at ESMO 2025. And actually was a positive trial in patients who had positive ctDNA post-radical cystectomy, either from the beginning or they converted from negative to positive later. In this DNA positive subset, atezolizumab was superior to placebo in terms of disease-free and overall survival, and that resulted in the FDA approval of atezolizumab in the adjuvant setting in patients with high risk of recurrence based on the pathologic stage, if they have ctDNA positive status. And I think that's an important point, is the DNA-guided therapy in the adjuvant setting. This resulted in the FDA approval of atezolizumab just recently based on the IMvigor011 trial. Of course, this trial included patients who were immunotherapy naive, so we cannot extrapolate this data from the perioperative immunotherapy trials. Speaking about immunotherapy perioperative trials, I will finish the doc here, covering two important studies that are mirror image of each other, and enfortumab vedotin plus pembrolizumab, EV-pembro as we call it, in cisplatin-eligible patients as a sandwich approach, perioperative. You see 4 cycles neoadjuvant, radical surgery, and then adjuvant therapy phase, compared to neoadjuvant Gemcis, 4 cycles with no planned adjuvant therapy. This trial was reported by Dr. Galsky at ASCO GU 2026 a few months ago. It was a positive trial, met the primary endpoint of event-free survival by blinded independent review committee, and you see here that the event-free survival endpoint was met, hazard ratio 0.53, impressive improvement, event-free survival with EV-pembro compared to Gemcis. EV-pembro was perioperative, Gemcis was neoadjuvant. And overall survival endpoint was also met. You see here perioperative EV-pembro was superior to neoadjuvant Gemcis, hazard ratio 0.65. And again, you see the separation of the curves and statistical significant and clinically meaningful improvement in overall survival. Pathologic complete response also relevant here because you see that the pathological complete response rate was 56% with neoadjuvant EV-pembro, only 33% with Gemcis, which is what you would expect with neoadjuvant Gemcis. Toxicity requires a lot of attention, merits discussion. We're going to discuss that also for metastatic disease with EV-pembro. Very important to educate the patients very carefully. Peripheral neuropathy, skin rash, pruritus, hyperglycemia, anorexia, fatigue, nausea, constipation, sometimes LFT elevation. I think all of those weight loss can be important, less risk of cytopenias, and of course, immune-related adverse events with pembrolizumab, extra attention across the board with EV-pembro, across with any regimen, I would say, we need to educate the patients well. So this is the summary slide for Keynote B15, and just the key message is that perioperative EV-pembro was superior to neoadjuvant Gemcis in terms of path CR, event-free, and overall survival. Toxicity was as expected, no new safety signals, and we're waiting for regulatory approval of this regimen for cisplatin-eligible patients. So something to keep an eye on for cisplatin-eligible population. EV-pembro, it's as we see here, seems to be becoming a new standard of care in this patient population as we wait for regulatory approval in these cisplatin-eligible patients. And in cisplatin-ineligible patients, we already have FDA approval of perioperative Ivipembro based on the KEYNOTE-905 trial. You see here the design, Ivipembro perioperatively, the sandwich approach, compared to no perioperative therapy in cisplatin-ineligible unfit patients. Significant improvement, dramatic improvement in event-free survival, hazard ratio 0.4, favoring perioperative Ivipembro, no surprise. Of course, very few patients got adjuvant therapy in the control arm. The difference, I think, is very impressive. And overall survival, also impressive data. Hazard ratio 0.5, favoring Ivipembro perioperatively compared to no perioperative therapy. So both EFS and OS, significant improvement. And you see here the pathologic complete response rate, 57% with neoadjuvant Ivipembro, only about 9% with TURBT alone, because the control did not receive neoadjuvant treatment. Toxicity, as expected, as I mentioned, I covered this already with a previous slide in the KEYNOTE-B15 trial, extra attention to the toxicity profile and extra education and close monitoring of those patients. So the summary here, you see that Ivipembro perioperatively, neoadjuvant and adjuvant, is FDA approved, and I think is the standard of care and strongly preferred regimen perioperatively in patients who are cisplatin not eligible. And as I mentioned a minute ago, we're waiting for the label to be expanded to include cisplatin eligible patients based on the KEYNOTE-B15 trial that I showed in a second. As I mentioned, these trials will keep showing data, longer follow-up, different subsets, quality of life data, biomarker data. So stay tuned for all this emergence of impressive data across the board in localized muscle-invasive bladder cancer. And with that, I want to thank you for your attention, covering all of data here. And I will again pass the baton to my colleague and friend, Dr. Garmezy, to give his important insights.
All right, thank you, Dr. Grivas. Now I'm going to give the community real-world perspective on muscle-invasive urothelial cancer and some of the curative intent pathways. So here's a good case, coordinating muscle-invasive bladder cancer with curative intent in a community practice. So we have a patient here, 72-year-old female, recently diagnosed with T2N0M0 muscle-invasive disease following a complete TURBT. Assessed for cisplatin eligibility, but the plan is neoadjuvant chemotherapy and execute a timely radical cystectomy. The patient is being managed in a busy community oncology practice, so scheduling the required cross-sectional imaging has a 3-week delay, and the local center does not perform high-volume cystectomies, so requiring coordination with a tertiary surgical center further away from the patient's home. And then there's some logistical barriers, like the patient's reluctant to travel for both neoadjuvant chemo and surgery due to transportation challenges and lack of local support. So let's do this polling question. Given a 3-week delay in securing staging imaging in your community practice, how would you adjust the curative intent pathway for a cisplatin eligible patient? Okay, thank you for those responses. Moving forward. So when I think about muscle invasive bladder cancer in the community setting, it's all about communication. Again, we go back to Dr. Grivas' setting, which is a great place to practice. You have urologists, you have medical oncologists, you have radiation oncologists. They're all under the same tax ID, they're all under the same roof, they're all under the same center, and they're all under the same system with similar incentives. Now, there's fragmented care in the community. That doesn't mean it has to be worse, but it's fragmented. I work in a medical oncology facility. I have to coordinate with urologists that do not work in my facility, which have their own incentive structures, as well as radiation oncologists that don't work in my facility or the urologist facility. So sometimes we have 3 different practices touching a patient to provide treatment planning. And obviously you can see how one that gets more complex, right? So again, we talked about TURBT needs to be complete. We need to get a CT scan and a PET scan. Who's going to order that? We don't need 3 of them, right? So is it the urologist's responsibility? Is the medical oncologist's responsibility? Who's going to actually take care of that? And how are we going to share the results around? Historically, and I put this in red, we assess for cisplatin eligibility, right? That may be changing. That's evolving. I think we're moving away from cisplatin in this phase of the disease. And then, of course, we need a discussion between medical oncology and urology. Are we going to do radical cystectomy? Or are we going to do bladder sparing with chemoradiation for a subset of patients? And how we work those in and how we make those decisions. It really needs to be a collaboration. And the medical oncologist really needs to talk to the urologist about what they saw before they really jump in and provide both options for that patient in front of them. And this all, 3 different practices potentially seeing a patient, has to happen in about a few weeks. Multidisciplinary review is critical. We need to trust the urologist on what they saw. And is that bladder what I call worth sparing? And I know that's maybe a harsh way to say it, but if the bladder is not going to maintain its adequate function after radiation, then chemoradiation may cause more downstream problems than cystectomy alone. So that's something that we need to keep in mind. We really need to trust our urology colleagues that we work with in these disease states. Now, let's talk about why maybe cisplatin is historic, and Dr. Grivas obviously talked about this as well, but looking at EV303 and EV304, with enfortumab vedotin and Nectin-4 targeting ADC with an MMAE payload, and I say the payload because it's important. I think that payload's more immunogenic than some of the other ADCs we work with in urothelial cancer. We give total of 9 cycles of enfortumab vedotin, 1 year of pembrolizumab, and what you can see here is EV303 is that versus cystectomy alone, those were cisplatin ineligible patients. Clear overall survival benefit, hazard ratio 0.5, pass CR rate 57%. In this trial, they gave 3 cycles of neoadjuvant EVP, followed by additional 6 cycles of enfortumab vedotin if able to tolerate, and a completion of a year of pembrolizumab. EV304 on the right is versus a cisplatin and gemcitabine control, right? That was the adequate control arm at the time. Now we have, that kind of cis-gem-nivo or cis-gem-durva. Well, this was designed prior to that. Some of these patients did get access to checkpoint inhibition as well. And you can see pass CR rate very similar, 56%. And again, it has a ratio a little bit higher, but the control arm is more active, 0.65, very statistically significant, clear curves on the overall survival. The event-free survival looks even better. And now the question is, that was 4 cycles of neoadjuvant EV because they thought the patients would be able to tolerate more therapy. Pass CR rates are similar. Do we give 3 or do we give 4 cycles, right? I think that's a question. Why maybe we'll be standardizing this over time. I'm personally trying to squeeze 4 cycles into patients who I think can tolerate it because it gets me more EV up front. So there's less that has to be done in the adjuvant setting. And I know that a lot of these patients are going to want to stop that EV. So I think it probably impacts survival to give more EV. So I want to give more of it up front. Now, if I'm worried about a patient tolerating it, I'll give 3 cycles. That way we can get them their curative cystectomy without causing more harm that may delay surgery. So those are the ways I think about that. So this is the new algorithm. We get a PET scan or CT scan. We share that amongst all our colleagues, which can be challenging because we're in different practices. We give 4 cycles or 3 if there's a tolerability concern. So that's 12 weeks of therapy. Then we get another CT cap. If our surgeon wants a urogram, we get that. And then we do cystectomy or in select patients, chemoradiation. And then we try to complete the 9 cycles of EV and 1 year pembrolizumab. Now, most patients will complete the year pembrolizumab. Not everyone will be able to complete all 9 cycles of EV due to tolerability issues, neuropathy, et cetera. I think the big question for the future is, can we use ctDNA and urinary DNA to guide how much therapy these patients actually require in the adjuvant setting? And I think it's still a question. It's not a definitive answer, but we can borrow data from IMvigor011, which I mentioned very earlier in this call, though I didn't have a slide on it at that time. This was presented by Dr. Powles at ESMO in 2025. Of course, there's a lot of data showing the positive effect of atezolizumab, but I want to just focus in on the fact that patients who are ctDNA negative after cystectomy do really darn well. So at 24 months, 88% are disease-free, 97% are alive. Now, of course, these aren't the only things that are important, but it does show in patients who are ctDNA negative, many of them will do really well. Now, my caution is the way that trial was conducted, we have really changed the landscape of treatment of urothelial cancer. These patients are living really, really long. We don't want to jeopardize decreasing survival rates off a trial by maybe stopping EV too soon. So I think that's something that we need to keep in mind, but I think there's hope and promise for the future here. And of course, I do use ctDNA if my patients are having side effects to make me feel better about stopping therapy. So what are the real world considerations, right? So we don't have a common EMR. There's no visibility. Patients get lost. It really is a bit of a challenge. And I say that because I live it, right? I live in this world. There's delayed imaging and inability to sometimes personally review the images, right? So let's say my urologists order the PET scan. Well, some of the facilities they order it, I have access to their packs. Other facilities I don't. So I need to get access. And that is timely, challenging, and complicated. And there's ways we have to navigate around that. We don't want to have to repeat imaging. That's expensive. Insurance won't pay for it. So we need to be careful. We don't want delays either, so that I can get imaging that's already been done 2 weeks prior. Now, there's also a limited amount of urologic oncology specialists, which can lead to delayed cystectomies, concern for metastatic spread in very high-risk patients. If these patients need to be referred from urologist to urologist, that does happen. Hopefully not too much happening on the metastatic spread standpoint. Of course, financial concerns, because there are generally repeated labs across facilities, repeated things that if we were all under one institution, we may not have to do. That goes back to communication. How can we minimize these accidental repeat orders? And then geographic distance, inability to coordinate in a timely way where we can't line up appointments appropriately. That can be hard. So what are some of our solutions, right? So we need to streamline communication. HIPAA, I'm going to be honest, is a barrier here. As much as we all want to just pick up the phone and text our colleague that works at the other practice, sometimes that's a bit hard, right? Can't always do that because we can't use names and other things in these non-compliant texting. So I think that's complicated. There's ways to do it. We all have our ways we do it, with secure messaging systems or secure emails and things like that. You need to work on getting PACS access to basically every imaging center across the region. That is easier said than done, especially when imaging centers are owned within a practice. There are always some concerns about that, but it really is essential to get that going. So if you're out there and you want to build up your program, you want to work with urologists or medical oncologists, kind of what we call across the street, then you really need to start doing this and navigating how to make that work for both of you. Obviously, thinking about nurse navigation, which can be virtual, so that patients don't get lost in the shuffle between practices. Difficult to navigate financial concerns of over-ordering, except for with communication. But also when we think about systemic drugs, often we can get free drug applications in patients who really need it. And I think virtual tumor boards have been a godsend for treating patients with muscle-invasive bladder cancer. In my community, we have 3 different practices coming together. We created virtual tumor boards, and we've created them actually full citywide, so that one hospital system sponsors them 1 week, the other hospital system sponsors them another week. Highly effective, has been a game changer, a revolutionary for the care in Middle Tennessee. But of course, that took in a lot of legwork. It took about 1.5 years to get off the ground. So these are things that you need to start working on now if you're interested, because they do take quite some time. So back to it, real world considerations. There's this real tension on how you create a pyramid or referrals to capture a few medical oncologists and a few urologists handling this multi-D complex management across practices. That's how we do it in our region. But of course, many of our other oncologists want to take care of these patients too. So that's another real world challenge, in the sense that in patients and providers with certain financial models wanting to hold on to these patients, but we really need to focus patient first, and everything else will flow from there. It's got to be communication 1, buy-in from your partners 2, right? Which is what I just mentioned. Patient first, practice second, right? When we're thinking about working across institutions, I think our GU community across 3 institutions is a very cohesive, tight group. We work together, even though we're all part of different practices, right? So it's patient first, practice second. Has to be a clear delineation of responsibility, and that may be different across medical oncology and urology based on the urologist and the medical oncologist. I know personally I have different models on who's ordering what with certain urologists, and then the exact opposite with other urologists. It all comes down to delineating who's doing what, so that you can establish the cadence of how these patients are going to be cared for in your clinic, who's going to order the biomarkers if you're doing biomarkers, and then the decision on who's going to follow that patient, order the surveillance scans, all these other things. It does get complex. Once you work it out, it gets easier and easier with every subsequent patient. Thank you.
Very good discussion overall about bladder cancer, and now we're turning our attention to metastatic disease. A lot to cover, but we'll try to make it as efficient as possible, because the treatment landscape has changed tremendously in the last few years. I will go in chronological order, and I'm going to start with the JAMAL Bladder 100 trial that we presented with Professor Pauls at ASCO 2020 during the pandemic. This was a patient population with disease control after platinum-based chemotherapy, GemCis or GemCarbo. Patients achieved disease control, stable disease, or response, and those patients were randomized to switch maintenance immunotherapy with avelumab plus best supportive care versus best supportive care alone, and that randomization happened between 4 and 10 weeks after the end of first-line induction chemotherapy. As you see, 700 patients were randomized in the two arms, and primary endpoint was overall survival. Stratification factors included best response to first-line induction chemo, a response versus stable disease, and the site of metastasis. So this was, again, a switch maintenance immunotherapy trial evaluating whether avelumab has a role. And the answer was yes. Avelumab significantly prolonged both progression-free and overall survival and became the standard of care in these patients who achieved disease control, a response, or stable disease after induction platinum-based chemotherapy in the frontline setting. So you have a patient with GEM-CIS or GEM-CARBO, they get 4, 5, or 6 cycles, they got a disease control, they went on to avelumab, and that prolonged survival significantly became a standard of care. Now, from June 2020, when actually avelumab became FDA approved, actually at the end of June of 2020, now we're moving over time to ESMO 2023, about 3 years later, and we saw data from ESMO 2023 with Dr. Michael van der Heijden, saw the data of the CheckMate 901 trial, and that trial actually reported important updates of, regarding the results of that trial that was in cisplatin-eligible patients, and that trial, as I mentioned, was designed long ago before the results of the JAMAL Bladder 100 were reported. So you see the control arm is GEM-CIS alone, without built-in maintenance immunotherapy. And this is because at the time of trial design, we did not have the results of the JAVELIN Bladder 100 trial. Having said that, about 20% of patients got maintenance immunotherapy, and about 40% of patients in the control group got immunotherapy at some point after before or after progression. That's in the control arm, in the GEM-CIS alone arm. In the experimental arm, we had the GEM-CIS plus nivolumab, and the question was whether the addition of nivolumab concurrently with GEM-CIS and then continuation maintenance for up to 2 years, whether it can improve survival. And the answer was yes, the overall survival endpoint was met. You see here significant improvement in the intent-to-treat population, hazard ratio 0.78, favoring GEM-CIS nivolumab over GEM-CIS as frontline treatment for advanced metastatic urothelial carcinoma. You see the curves separate and they stay separated. You see about half of the patients are alive in 2-year mark with GEM-CIS nivo, compared to about 40%, 41% with GEM-CIS alone. You see here the median overall survival, 22 versus 19 months. You can argue an incremental difference, but statistically significant. And similar story, PFS endpoint was also met. You see that the median PFS is about the same, about 8 months in both arms, but with longer follow-up. Some patients on nivolumab arm stay recurrence-free and alive. You see here about a quarter of patients were alive and recurrence-free with nivolumab addition to GEM-CIS at the 2-year mark, and the hazard ratio was significant here, p-value significant for PFS. Toxicity, as we discussed before, the Niagara trial, that if you add a checkpoint inhibitor to chemotherapy like GEM-CIS, we need to be thoughtful about immune-related adverse events, but overall seems to be a feasible combination with expected side effects. And that brings us to the EV-302 trial that was also presented at the same ESMO plenary session in the presidential symposium, to be more precise, in the ESMO 2023. And we experienced a wonderful standing ovation when Professor Pauls presented the data at that presidential symposium in 2023. And I remember that the data were really impressive. This is a frontline setting of advanced urothelial carcinoma, patients getting EV plus pembro combination, the same regimen that we already discussed in muscle-invasive disease setting. This is, of course, here metastatic frontline setting. So pembro EV compared to GEM-CIS or GEM-CARBO. And here is an interesting, again, point that because of the timing of the trial design, there was no built-in maintenance avelumab in the control arm. About 30% of patients received maintenance avelumab in the control arm, and about 60% got immunotherapy at some point before or after progression. So just for context. And of course, EV pembro here, EV was continued until progression or unacceptable toxicity. Pembro was given for 2 years. for up to 2 years. And here you see the very impressive difference in survival curves for PFS by Blunt Independent Review Committee in the overall population. You see a doubling of the median PFS. You see hazard ratio 0.48, and really impressive difference favoring EV-Pembro compared to GemCis or GemCarbo. And here's the overall survival data. You see impressive, again, hazard ratio 0.5 favoring EV-Pembro compared to GemCis or GemCarbo. And you see here that if you look at the 2-year mark at the initial data cut, 60% of patients were alive at the 2-year mark with EV-Pembro compared to 35% with chemotherapy. Again, impressive data set. And the benefit in terms of overall survival and progression-free survival seems to be across the board, across several pre-specified subsets of patients, again, favoring significantly, I would say, EV-Pembro. Toxicity, we already talked about that important point in EV-303 and 304 trials. In localized muscle-invasive bladder cancer, the Keynote 905 and Keynote B15 that we'd covered before. But that's a reminder here, peripheral neuropathy, skin rash, pruritus, rarely Stevens-Johnson syndrome, alopecia, fatigue, anorexia, weight loss, nausea could be happening, hyperglycemia, about 10% of patients with EV-Pembro, and very low risk of cytopenias. Again, it requires significant discussion with the patients. Before I go to erdafitinib, I want to point out that we saw some impressive data from ASCO 2026 by Professor Pauls with longer follow-up with EV-Pembro data from the EV-302 trial, this same trial, with about 3.5 years follow-up. And if I remember the data, about 44% of patients were alive at the 3.5-year time point with EV-Pembro. Again, impressive. We see some, long-term survivors there. So it begs the question, are we curing some patients with metastatic disease? Of course, it's impossible. It's not possible to know at the individual patient level, but I think as an aggregate, I think we're starting to cure a number of patients in this setting. Erdafitinib is a very important FGFR inhibitor, and this is a very important trial, the Thor cohort 1. Erdafitinib was compared to taxane chemotherapy or vinflin in Europe in patients with platinum refractory, I would say, to be accurate, immunotherapy refractory metastatic urothelial carcinoma. The vast majority of patients had also received platinum chemotherapy, but based on an eligibility, prior immunotherapy was mandated. But just because of the prior therapies, most of patients ended up having prior platinum chemotherapy in that trial. But again, immunotherapy refractory patients were selected based on the tumor tissue presence of any activating mutation or fusion rearrangement in FGFR3. Then you see here the primary point was overall survival that was met. Erdafitinib was superior to docetaxel or vinflin in that setting. So genomic testing is very important. It's critical. Every time you have a patient with newly diagnosed metastatic disease or advanced disease and not amenable to curative intent, it's important to send immediately genomic testing, tumor next generation sequencing, including FGFR3 alterations for erdafitinib. These are present in about 20% of patient populations, about 15% in bladder cancer, and about double, about 30% in upper tract urothelial carcinoma. So make sure you do your tumor NGS testing. This was a positive trial, and you see the benefit seems to be across the board, more or less, different degrees of benefit across different subsets of patients. The cohort 2 compared erdafitinib to pembrolizumab in platinum refractory setting. Patients had platinum chemotherapy, refractory progression. Erda was compared to pembrolizumab. Again, selection based on FGFR3, activating mutation or fusion. And you see here there was no significant difference in PFS or OS, very similar, but the response rate was higher with erdafitinib, about double compared to pembrolizumab, so high response rates. So you have someone with bulky disease, symptomatic, maybe visceral metastasis. Erdafitinib is a reasonable option if you have the FGFR3 activating mutation or fusion, of course. And pembrolizumab had about half of the response rate, about 22%, but had more durable responses. So that's why there was no difference at the end in survival. Toxicity profile is very important to keep in mind. With erdafitinib, hyperphosphatemia, stomatitis, diarrhea, dry mouth, nail changes, hand-foot syndrome, hyponatremia. Patients have to see an ophthalmologist or optometrist at baseline and during treatment, and also a nutritionist to talk about phosphorus diet. So important, again, to keep in mind. One word about sacituzumab govitecan, antibody drug conjugate against TROP2, carrying a topoisomerase 1 inhibitor payload. This was approved by the FDA as accelerated approval in April 2021 in patients with platinum refractory immunotherapy refractory metastatic urothelial carcinoma based on the phase 2 TROPHY-U01 cohort 1 trial. And after that, of course, the eyes were turned to the phase 3 trial that I'm showing you here, TROPIC-04, sacituzumab govitecan compared to taxane or vinflunine, 1-to-1 randomization, primary endpoint was overall survival. To our surprise, this trial did not meet the primary endpoint of overall survival. There were a number of reasons. Number one, of course, the efficacy is relevant, but also in this trial, we did not mandate primary prophylaxis with growth factor. And I think that was relevant because there were a notable number of deaths because of neutropenic sepsis. So if this drug is being used in this patient population, is very important, critical to use primary prophylaxis with growth factor from the beginning, from the first cycle to reduce the risk of neutropenic sepsis. Of course, other factors may play a role. For example, dropout, in the control group. About 20% of patients got enfortumab vedotin as salvage therapy in this trial, so that can potentially also impact overall survival. So again, these are some of the reasons why TROPIC-04 did not meet the primary endpoint of OS. And I want to mention here that based on that results, sacituzumab govitecan, the label was withdrawn in the fall of 2024 by the company. However, it's still listed in the NCCN guidelines as a later line option. So if you use it in this patient population, make sure you use, as I mentioned, with primary prophylaxis with growth factor. And last but not least, anti-HER2, a lot of discussion, but this is another option. Trastuzumab deruxtecan has a pan-tumor FDA approval based on the results of this trial, Destiny Pan-Tumor 02 trial. You see a basket trial across multiple cancer types, and you see specifically there were 41 patients with metastatic urothelial carcinoma, 16 had IHC 3+, and about 20 had 2+ based on the gastric scoring system for IHC. And you see the robust response rate, 56% for IHC 3, 35% for IHC 2+, using the gastric scoring. This is an option for patients, so make sure when you do your tumor genomic testing, please add the HER2 IHC and specify gastric scoring system. Very important to evaluate for trastuzumab deruxtecan. The NCCN guidelines mention that, and the FDA approval is only for 3+. So based on the FDA label, it's only IHC 3+. But in the NCCN guidelines, they now also mention 2+ as an option. So there's some, again, question here about the 2+, discordance between the FDA label and the NCCN guidelines, but something, again, to keep an eye as an option. And this is the last slide summarizing what I said so far. EV-Pembro, unless was used recently before, is a standard of care in the frontline setting. Whether, of course, is available across different countries is another question about access to care. But assuming it's available, it's a standard of care. Again, unless it was recently used in a localized setting, that's a different question. Other options are listed in the slide, GEM-CIS plus Nivo, GEM-CIS or carbo followed by available maintenance, especially if EV-Pembro is not available. And of course, the subsequent lines of therapy depend on tumor genomic testing, HER2 IHC, gastric scoring system, and of course, what prior treatment the patients receive, performance status, comorbidities, toxicity profile, level of evidence, patient preferences, provider familiarity. All of those factors can impact decision-making. And of course, clinical trials remain very important. That's how we make progress. Thank you for your attention. I'm going again to give the microphone to my colleague, Dr. Garmezy, to provide his important comments and talk, and then we can go for question and answers.
All right, moving into the final portion tonight, metastatic urothelial carcinoma, systemic therapy and follow-up. Thank you, Dr. Grivas, for talking about, for giving that first talk. And now we're going to kind of layer in that community and real world perspective. And we're going to start with the third case here, managing advanced muscle invasive urothelial, not muscle invasive, metastatic urothelial carcinoma and treatment handoffs at the hospital level. So we have a 65-year-old patient with metastatic urothelial carcinoma with liver and lung metastasis. that initiated on first-line enfortumab vedotin and pembrolizumab. Treatment was initiated in an academic hospital where the patient lives 150 miles away in a lower resourced area. So the patient requires frequent monitoring for severe adverse events. Of course, we know these things: skin reactions, hyperglycemia, pneumonitis, etc. And the local primary care and community oncology teams have a limited capacity and familiarity with managing the specific toxicities of this regimen. Remember, many community oncologists will only see a few urothelial patients a year, if that. The patient cannot maintain biweekly travel to the academic hospital for ongoing infusions and toxicity checks due to logistical fatigue, which of course we all understand. So, polling question: in managing this patient's follow-up care locally, which clinical finding represents your absolute refer now trigger to send them back to the academic hospital? And please look at these options below. Okay, thanks. So this is a slide I created not too long ago. This was the recent history of the treatment of metastatic urothelial carcinoma. You gave chemotherapy or EV pembro if they were cis ineligible, so you gave cisgem. And then if they progressed on that and they hadn't seen immunotherapy, they got monotherapy, immune therapy. And then if they hadn't seen enfortumab vedotin, they got that. If they were FGFR positive, you could give erdafitinib. And then they moved on to sacituzumab govitecan, which is a TROP2 antibody drug conjugate. But there's been a lot of changes. Basically blew up the treatment paradigm in metastatic urothelial carcinoma. It's now EV pembro for everyone in the front line if they hadn't seen it perioperatively, but many of our patients haven't yet. That treatment paradigm just being worked in now. And then after that, it's chemotherapy with cisgem or carbogem, but real world response rates are relatively modest. Durability is really low after EV pembro. We've seen some data sets showing that durability is about 4.5 months. Very toxic regimen for durability that poor, in my opinion. Erdafitinib still only for the minority of patients with FGFR mutations. It's about 15%. Sacituzumab govitecan is now no longer FDA approved based on its failure in TROPiCS-04 to beat docetaxel. Now we do have the ability to give trastuzumab deruxtecan for HER2 3+ is the FDA approval, but some patients can get it at 2+ given the response rates there. HER2 response rates on that drug about 50-ish% in patients with 3+ and about mid-30s for patients with 2+. So realistically, you give EV pembro, if they're not eligible for HER2-directed therapy or FGFR-directed therapy, there's not a whole lot out there and really need to refer for clinical trials. But again, talking about in the community, that's not always the easiest thing to do. So one of those maybe triggers right there to refer to either an academic center or a community research center of excellence. Now, community treatment is a little bit different. And I used to practice at MD Anderson, and now I practice at a standalone oncology clinic. And I'm very proud of the oncology clinic I practice for. It is a community clinic, but it is also a very, very research-driven community clinic. And we have world-class medical oncologists that sit next to me. That being said, we are still working within the community and using community resources for everything else, right? So there's significant barriers to therapy, even in my practice. We have travel distance. We have limited specialty availability, dermatology, endocrinology, neurology. And you love to see, and no offense to my academic colleagues, but I go to all these meetings and our academic colleagues it's so important to have multidisciplinary input on the management of these side effects and working with dermatology and working with other subspecialties. And then I always go ... But are the ones that I'm working with even used to oncology patients? Have they even seen an enfortumab skin rash, right? So actually sometimes the medical oncologist community is actually the best person to be managing these side effects. And it goes back to why we have internal medicine training prior to medical oncology training, so that we can understand, be aware, and learn how to manage these side effects. Because most toxicities can actually be managed by the oncology clinic and probably should be. Not all, but most. So let's talk about the dermatologic toxicity with enfortumab vedotin. And you can see here, this was published in Frontiers Oncology in 2024. I find it quite helpful looking at grade 1, 2, 3, 4, and thinking about when can I restart at the same dose. And I'm going to make it a little bit easier, right? So here's my algorithm on the left side of the screen. You can look at the official algorithm on the right. But for me, grade 1s, I'm trying to just give triamcinolone. I'm trying not to give systemic therapy that might blunt the effect of pembrolizumab. At grade 2, I'm giving triamcinolone alone, maybe, but sometimes I actually give 3 to 5 days of prednisone. Now, if it's a true bad grade 2 rash, then yes, I'm going to follow with a more extended taper. I'm going to do a couple of weeks of systemic steroids. But often with a grade 2, if you catch it early, you can give a few days to really drive down that initial response affecting that toxicity, and then give triamcinolone. Now with grade 3, you need to be giving prednisone 1 mg per kg. I oftentimes, to make things easier, they're in my clinic, I'll give them Dex 20 IV to really hit them hard to try to prevent any further propagation of that skin rash that might send them to the hospital later. And then I'm giving systemic prednisone for extended taper, and I'm layering in triamcinolone as well. I'm really throwing everything I can at them. At grade 3, sometimes I'm considering dermatology, but really those are the patients that aren't responding. I see those patients back either somewhere between 3 days or a week after we initially saw them. And if they can't come into clinic in 3 or 4 days, we often use photography to help guide us. Grade 4, that's when you're calling dermatology for sure. You're worried about SGS or TEN, you're calling dermatology, you're admitting these patients, you're giving IV steroids. And I think the key here is if you see people on cycle 1, day 8, you can prevent a lot of these bad skin tox rashes from getting worse. They're much easier to control if you catch them early. Sometimes you need to see patients on cycle 2, day 8 as well if you're nervous. And again, considering photos through patient portals and things like that has been instrumental in the community of taking care of these patients that live further away. Now, hyperglycemia is one that, I'll be honest, I didn't love the idea of having to start managing. But if you are going to treat a lot of patients with bladder cancer, whether it's muscle invasive or metastatic, you now need to learn how to treat hyperglycemia, because approximately 10% of these patients are going to get it. Remember, the clinical trial excluded patients with a hemoglobin A1C of 8% or greater. A lot of us are going to treat these patients in the real world. They're going to be even more prone to hyperglycemia, right? Medium time to onset is under a month, so it does often happen early. The risk factors are obvious: history of diabetes, baseline hyperglycemia, and baseline elevation in hemoglobin A1C. I think the other thing to think about is the BMI over 30. If a patient's with diabetes on insulin and we give them this drug, we can tweak the insulin. But it's those BMI over 30 patients that we run the risk of tilting them into diabetes, requiring insulin or other therapies for the rest of their life. Doesn't mean we should withhold the therapy from these patients. We just need to monitor them more closely and understand the risks there. And then, of course, we want blood glucose to be under 250 prior to treatment. We had to buy finger stick glucose monitors in clinic to get quick labs back on those day 8 visits, et cetera, before we redose those patients. So that's a good tip. If you don't have those in your clinic, just go ahead and try to invest in those. For the cost of it, it's quite beneficial. So what else did you have to learn as a community oncologist? You need to learn how to give oral hyperglycemic medication. So metformin's an easy one. You up titrate that. If you start too high too fast, you can run the risk of GI side effects like diarrhea that may have a patient actually discontinue that therapy. Looking at sulfonylureas, there's other drugs out there. You need to get comfortable with a few of these, not all of these, just metformin plus 1, so that you can help manage those patients in clinic. That's my advice. Get familiar with metformin and pick one other oral hyperglycemic to get familiar with. And then you might need to prescribe long-acting insulin in some of these patients. These patients are going to need logs so that you can titrate them. Education's critical. You need pre and post glucose values multiple times a day. If you're able to, that's when I'm referring to endocrinology. So I'll start the metformin and these other drugs myself. Once they start needing long-acting insulin, I'm trying to get them in with endocrinology. That can take 1 to 2 months in the real world, sometimes longer. So I'm also managing that long-acting insulin. Now, if long-acting insulin is not enough and they need some kind of basal bolus regimen with short-acting insulin, those patients need to go to endocrinology unless you really are a superstar from your internal medicine days. But I don't manage those patients in my clinic. Those patients are immediately referred to endocrinology. And because I'm not referring all my patients to endocrinology, I can pick up the phone and call the endocrinologist, say, hey, this is the one that needs you this week, right? Because I'm not over flooding their system with every single patient who develops hyperglycemia on this drug. And then you also need to remember pembrolizumab can cause diabetes type 1, right? So you can look at C-peptide levels, what's consistent with ICI type 1 diabetes. Low C-peptide might be more indicative of that. Those are going to need more urgent endocrinology because those patients are going to look more like a type 1 diabetic than a type 2 diabetic. So thinking also about the other endocrinopathies associated with checkpoint inhibition, thyroid dysfunction. Generally, if they go hyperthyroid, you can continue to treat and just watch until the thyroid burns out. If they're symptomatic, you're going to have to layer on therapy. Hypothyroid, you can continue the therapy and just provide that Synthroid and titrate that. I do that myself. I do not refer to endocrinology for that. More complex things like type 1 diabetes, hypoparathyroid, pituitary dysfunction, those often go to endocrinologists in my clinic. Primary adrenal insufficiency, if it's easy, I do it myself. Hydrocortisone, 20 or 10, 20 in the morning, 10 in the night, or 10 in the morning, 5 at night, depending on how much they need. But if it's anything more complicated than that, I'm referring them to endocrinology. But here's why. That sounds scary, right? But here's why we do it. Updated overall survival. This was presented at ASCO just a few weeks ago by Dr. Powles. At 3.5 years, an estimated 44% of patients are alive with EV Pembro. And it does look like we have a tail of the curve forming. I personally think I've cured patients with metastatic urothelial carcinoma with this regimen, right? It's only been 3-4 years in my clinic since we started giving it. But I have a couple patients that are off therapy with complete responses in negative ctDNA that I think are probably cured. I'm going to knock on my desk wood really loudly right now, not to jinx it. But nearly everyone deserves a chance at EVP. So if they're diabetic, I give EVP. Everyone deserves a chance at these outcomes, right? And we just need to learn how to manage these side effects. Now, the other thing that was presented at ASCO, which I think is interesting, is it shows that basically a lot of these events, they tend to happen early. There's not an increasing accumulation of toxicity as patients move from that less than 1 year to 1 year to greater than 2 years side effect. What's not captured on this is, of course, neuropathy does increase. To me, neuropathy with enfortumab vedotin is not an if, it's a when. Everyone's going to get it, and that's when we need to start thinking about dose reductions and dose interruptions. So can toxicity be managed locally? It might. In some situations, almost certainly. Grade 1 and 2, yes. Some grade 3 skin rash can be managed locally. But if you need concerns, you need to get them to a specialist. Hemodynamic stability, they have to be hemodynamically stable to manage locally. You have to be able to get repeat labs in 48 to 72 hours. They need to be able to communicate rapidly with clinic. Maybe that's pictures, maybe it's not, if they're too far from the center, but you have to have that ability to actually appropriately manage them as an outpatient, because if we don't get these adverse events under control quickly, they can get out of control fast, and patients can die of skin rashes and other toxicities from enfortumab vedotin. So we need to be careful when we manage these patients locally. So with that, thank you all. We'll open up some discussion. I'm here for questions, but I'm also going to put my email here to discuss anything related to bladder cancer. My email is ben.garmezy@scri.com.
I want to thank you so much for your attention. And before we move to questions, I'm just going to bring up on screen our QR code for today's session. You will need to scan this whenever you're leaving to claim your CME certificate, which is completely free. I will also place the link in the chat box here so you can show it again at the end. Thank you so much. And now we have some time for questions. And let's move on with the first question. Ben, so much is going in the field here. It's really wonderful to see that happening. Starting with the first question, in community practice, and Ben, you can start answering this. We frequently receive general pathology report that lack specific critical details, like the presence of muscular dystrophy, for example, or histology subtype, variant histology, TURBT or LVI. Given a real-world constraint, when we have people driving a long distance, and of course, having the need to see urologic oncology, how do we clinically decide when it is important and prudent to repeat TURBT, especially with the risk of understaging that it can be up to 50% when in a T1 high grade when we miss muscular dystrophy, and up to 20% or more even if we have muscular dystrophy. So what's your comment about the need to repeat TURBT, and if you have a worry about a T2 when the report says T1, and any other comments regarding that pathology report and clinical staging?
Yeah, I mean, I think that's generally pretty critical. Sometimes we can navigate around it, and we do have to navigate around some of these things. So if you have a T1 and you read through the cystoscopy report and the urologist thinks that it's a very large tumor and you don't have muscle on the tissue sample, we have to go back in and do a repeat TURBT unless it's medically not feasible. But generally speaking, it is. Now, if we're starting to have a T1 tumor and we couldn't get the muscle because it's so large and it's choking off a ureter, leading to hydronephrosis and kidney failure, and we're sticking tubes in and all these other things, well, this is a patient that's not going to go forward with intravesical therapy anyways, and it might be okay to give them emergent systemic therapy with such as enfortumab vedotin and pembrolizumab, with the assumption that it's muscle invasive, with a safe, shared decision-making with your patient in order to speed things up. So I think it really depends on the clinical situation. But if you have a T1 lesion that can wait, but you didn't have muscle in the sample, those patients need to have a repeat TURBT, of course. And then when you start to think about some of the other things like variant histology and lymphovascular invasion, it depends if it's going to change management. Now, I'm always on the phone calling my pathologist when I don't have this to see how fast I can get it. But you can't always get it depending on what that sample was at what outside hospital, what outside facility. And if we think that the majority component is a urothelial and we don't think there's any neuroendocrine, so maybe there's some amount of squamous or some amount of plasmacytoid or micropapillary or whatever it may be, is that going to change what I do? And the answer is it often is not, because I'm probably still going to give that ADC-IO combination to the majority of those patients. Same with the lymphovascular invasion. While that gives us prognostic information on a muscle invasive specimen, it's not necessarily going to change what I do. So that's kind of how I act in the community.
Thanks, Ben. Very comprehensive and very helpful, valuable answer. And, the other question that goes with it is, doing the TURBT locally versus referral to a tertiary center. I think, and I would love your comment too. I think it's great to have multidisciplinary approach, and many colleagues in community, urology colleagues, they refer patients to us because we have a multidisciplinary bladder cancer clinic where you can review all the information, imaging, TURBT, exam under anesthesia, all the information. It can be one-stop shop for the patients. Of course, it's not easy, to replicate that multi-D model across the board. But I think having, at least discussion with tertiary center is important. And then maybe communication, right? Maybe, it's a complex case and TURBT can be done by a urologic oncologist who does it more often versus locally based on scheduling considerations. But I think that requires communication, I think, between, urology and, of course, in certain cases, medical oncology and urologic oncology at the same time. And as you said, the clinical stage is not only based on the path report. You made a great point, Ben, that clinical stage is a, consideration of, pathology reports, exam under anesthesia and imaging, right? And sometimes it's a T1 on path, but it's a clinically T3, by consensus, by imaging. So that's a great point there for sure. Any additional comments on that, Ben, before we go to the next question?
No, I don't think so. Just honing in though on the communication, I think you need to know what the appetite is for your local urology colleagues if you're a medical oncologist, right? We have to share these patients, share referrals, make sure that relationships stay healthy and that there's trust. And so absolutely referring patients for an academic center, if your local urologist can't do it, is totally fine. You just need to share that communication and the reasons behind what you're doing.
Thank you, Ben. Yeah, I think communication is essential to your point, and it cannot be emphasized enough, as you said. And also, try to expedite, getting people in. So access is key, and avoid delays because, you have a curative intent scenario. You want to move fast, avoid delays in treatment. Of course, having all the diagnostic elements as much as possible to, drive in well-informed and shared decision making. Talking about decision making, another question that comes up, Ben, is about the national shortage of BCG in the United States, and some areas affected more than others and can be variable over time. Many colleagues and practicing oncologists and urologists may be forced to initiate alternative intravesical therapies like intravesical chemotherapy with gemcitabine and docetaxel to avoid treatment delays. And if a patient with high risk shows an incomplete response or early recurrence on this, let's say, intravesical chemotherapy combination, how aggressive should urologic oncologist colleague be in terms of restaging, and also think about BCG unresponsive disease and intravesical options for that setting, like TAR-200 or nadofaragene or the interleukin-15 plus BCG option, all the FDA-approved therapies. In that case, when you have let's say, a case with no prior BCG because of shortage, and of course, radical cystectomy can be an option there as well. What are your thoughts?
Yeah, no, I think this is one that actually needs to be referred out, right? So if you don't have the ability to give BCG in your local community or don't have the ability to try some of these novel agents, anyone who has true non-muscle invasive disease that doesn't have bad variant histology that might warrant immediate cystectomy or doesn't have something that makes you very concerned on the cystoscopy that you need to move quickly deserves the right to actually hear about some of these other agents, at least spare that cystectomy for some time. We shouldn't be jumping straight to surgery without giving the patients their options. So a lot of centers have better BCG service lines. This is something we see throughout the country. In my relationship with SCRI, where we have a coast-to-coast network, we're understanding that some areas have access and some areas don't. And this is where we just need to refer patients where there's access to BCG. And if we can't get BCG, I think TAR-200 is fine. I think Adstiladrin is fine. I think a lot of these agents are okay. I don't want to mess around too much and give them overly sequentially where we're giving 3 in a row. But if you've just given intravesical chemotherapy, I do think we should try something else first before cystectomy the majority of patients.
Thanks much, Ben. Very, very, important, as you mentioned, referral and communication with tertiary centers, and, I have this discussion with our colleagues in urology all the time. And, as you alluded to, one size may not fit all, and maybe some patients who could benefit from a discussion, of intravesical therapies versus radical cystectomy. And, some patients may need radical cystectomy, some others can go with intravesical therapies. And that's, a very elaborate, nuanced discussion that, can be facilitated by expert urologic oncology colleagues who have experience with both radical cystectomy and intravesical therapy options. And of course, availability of clinical trials is another important point. The last quick comment I have is that my colleague Dr. John Gore, University of Washington, published recently at JCO the CISTO study, CISTO, a pragmatic study that looked at patients who opted for bladder preserving intravesical therapy versus radical cystectomy. And I think this study was very interesting. I looked at quality of life domains, and some patients, in some quality of life aspects, interestingly, some of those aspects of quality of life favor radical cystectomy. But of course, it depends on the setting, burden of disease, and time of recurrence, and many other things. But I think the availability of intravesical options is great, and now we have many, to your point. So definitely important to have this discussion. Thanks, Ben. We're going to move to the next question here. Sticking with the theme of non-muscle invasive disease, interestingly, we had recent FDA approval of durvalumab based on Potomac trial in BCG naive, high-risk non-muscle invasive disease space, based on the trial that compared BCG induction and maintenance alone versus BCG induction maintenance and durvalumab intravenously. And of course, a big question here, Ben, for you is you and me have experience with giving systemic checkpoint inhibition, and maybe about 10 to 20% sometimes risk of significant immune-related adverse events, depending on the duration of treatment, in a community or rural setting with limited access to subspecialized supportive care, non-oncology specialties, rheumatology, pulmonology, GI, endocrinology. How do you think about identifying ideal candidates for intravesical BCG plus durvalumab in the context of the recent FDA approval?
Yeah, and I might take it one step further. How do we, even in a resource-rich environment, identify the right patients for durvalumab? I think the risk of overtreatment here is incredibly high. Now, would I give it to a subset of patients? Yes, it's those patients that have high risk NMIBC, and it's sometimes more voluminous than others, right? This is when it goes to, you really have to pick up the phone and call your urologist. What did they see in the cystoscopy? I gave a patient an IO BCG combination. They had upper tract disease, they had lower tract disease. It was all non-muscle invasive. The upper tract disease was a little bit lower grade, so we felt confident in that. And that was successful. But this patient had high volume disease. We're trying to prevent a massive surgery. So I think there are situations where we should give it. I think in resource-rich environments, it's a little bit easier to give. I think if you are in a limited scope of practice without a lot of comfortability in subspecialty care and managing some of the high-risk IO toxicities, the worst thing to potentially do is give an agent that has a very small benefit in event-free survival, though it is tangible, it is there, a few percentage points, about, I think, 5%, versus a relative risk that's a bit higher of life-altering side effects. So to me, I think the question is, it's not for everyone, and only those really, really high-risk situations.
Thanks, Ben. It's a great debate for conferences and meetings. And as you said very eloquently, we have to balance benefits and risk. And, the hazard ratio for, looking at reducing the risk of high risk recurrence in the bladder or progression to muscle-invasive disease. And of course, versus, the risk of toxicity, to your point. And in the Potomac trial and also in the other trials, the CREST and the Alban trials, very few patients had actually progression to muscle-invasive disease. So I think it's, as you said, case by case and very detailed, nuanced discussion about pros and cons, individual patient level. Maybe patients with very high risk that may be cystectomy up front, may be considered, maybe those are patients who may be candidates for the combo. I think it's to be defined, and we'll see what happens in clinical practice. And I think it's I'm sure more and more discussions will happen in that domain. A side comment that I usually add in those scenarios is when you have, especially to your point, multifocal disease, upper tract disease. I also think about germline testing and genetic counseling, because some of those patients have germline mutations, and this may be also relevant to their broader families, for cancer risk assessment for men, women, for different cancer types. As a side note, because we see more and more germline mutations these days in urothelial carcinoma, upper tract or bladder cancer. Can go to, I think we can have time for one more question, my friend, here. And, I know you and me have been talking about, multidisciplinary care and tumor board. And the question is, if we're utilizing a virtual tumor board or nurse navigator to expedite care, is it ever appropriate to initiate neoadjuvant treatment, for example, EV-Pembro, based strictly on the local TURBT findings while waiting for the scans to be done or to, be evaluated? It's pretty much going back to this coordination question that we discussed before.
Yeah, I mean, we definitely need the scans done before we start, because if we're going to talk about a localized versus a metastatic patient, we need to be pretty darn sure before we do anything like definitive radiation to the bladder or cystectomy in a patient who had metastatic disease that then we rendered into maybe a radiographic CR because we gave them neoadjuvant therapy. So I think that's number one. Now, I have never personally started therapy when I was waiting to get the scans. Even if I haven't personally gotten the imaging, I at least want to see the report before I start. That way I can better counsel the patient on the risk versus benefits. These are not benign drugs. That being said, the treatment management probably isn't going to change in the majority of patients. If they have MIBC, you're going to give them generally that EV-Pembro, and then you're going to see restage them after 3 to 4 cycles with cystoscopy scans and imaging. But I personally have never done that. I would want to at least have the report in hand generally to talk to that patient.
I agree with you, Ben. I think it's critical to have imaging done and reviewed images and a report before treatment starts, because it sets the stage for the treatment setting. Is it localized disease with curative intent treatment, or it's metastatic with, kind of palliative intent treatment? I think the role of local regional therapy depends on that. And of course, there can be gray zone scenarios, but I think, having pathology review and radiology review before you embark on treatment is critical to have all the necessary testing done. And, I think that can be very, very useful for the patient. In addition, of course, to having detailed history, physical exam labs, I think having complete staging, imaging, images, a report, and the pathology available, all of them are very important.
And 1 week to get 1 week to get that, you call the radiology center, get it faxed over or emailed, is not going to harm the patient relative to jumping too fast, right? So I think that's good to keep in mind. Yeah.
Good points, Ben. Having, as you said, try to expedite, but I think, having all the ducks in a row and the right diagnosis, right setting, all the details is important, to your point. And as you said, all the efforts to expedite things, but you need all these components in place. Last question, my friend. So while EV plus Pembro is firmly established here in the frontline setting of people with newly diagnosed metastatic urothelial carcinoma, there is a challenge, right, in case of progression. And you may argue, you may have maybe a third of patients or so who may have long-term remission and may not need other therapy, which is great if they have long-term remission. But you can argue the majority of patients probably would have at some point variable time point progression. And I know you and me have talked about the TROPiCS-04 TRACY trial that I had the chance to present at ESMO in December 2024. We published it at Annals of Oncology with Tom Pauls and others. This did not meet the primary endpoint with sacituzumab govitecan versus taxane. The question is, what do you do in second and third line and beyond? How important is to have the results of tumor genomic testing available, FGFR3 alterations for erdafitinib, and now here too IHC based on the gastric scoring system for trastuzumab deruxtecan? How do you sequence those therapies? Platinum-based, biomarker-based? What do you think?
I mean, it's critical. And I'll tell you, I may buck convention, so I may get in trouble right now from you. But look, well, here's what I do. You're giving enforcement vedotin and pembrolizumab to the majority of your patients, right? And you need the biomarker testing started right there because you're a chess player, right? What's my second move if this fails? FGFR critical status, you need to know it on everyone. It's about 15% of patients or so. And then you need to know HER2 now, because if we don't have either of those biomarkers and we're negative for both, our option is doublet chemotherapy or single chemotherapy, right? Doublet chemotherapy versus single chemotherapy. I don't know how relevant that is because the doublet chemotherapy in the real world seems to have a median radiographic progression-free survival in some small studies out of some of the academic centers of only 4 to 5 months. So it's not that impressive. It's certainly more toxic than docetaxel. Now, that is the standard of care in those patients, but it's not a standard I like. When you look at FGFR versus HER2, I think that's a more nuanced discussion. In my patients that are HER2 3+, I'm probably leaning a little bit more on giving that HER2-related therapy, right? That is now in a small subset, I think it was 18 or 26 patients or something, but the response rate was over 50%. We know that drug is a miracle drug in breast cancer. It works very, very well in urothelial cancer as well in that 3+. Now, if it's 2+, I'm more on the fence between giving that drug and giving erdafitinib if they're FGFR positive. They can co-occur. They don't always, but they can. They're HER2 2+, the response rate dips into the mid 30%. Erdafitinib is about 40%. Erdafitinib is a oral drug daily. Maybe that's better for some of your patients. The other drug's IV, right? But also erdafitinib, the toxicity is it's not better all because it's oral. It has the nail issues, the phosphorus issues. People don't feel great on that either. So I think that's more of a nuanced conversation. And I don't think there's I've gone both ways on that situation. And then when you talk about, okay, I have erdafitinib and I have, in HER2 or faz-transdecan deruxtecan, because I'm not supposed to use trade names. I'm sorry about that. But, I actually would give both of those drugs maybe before platinum doublet combinations in the second line, even though that is not what the guidelines say. So I might get in trouble. What would you do?
Great discussion, Ben, and I totally agree that it's critical to have the tumor genomic testing and the HER2 IHC using the gastric scoring upfront at the time of diagnosis of metastatic disease to have it available when there may be progression. And I think you raised great points. Second line, let's say in the absence of a clinical trial, do you do platinum gemcitabine? And that if you do platinum gemcitabine, it's a patient candidate for cisplatin or carboplatin based on neuropathy from UV, for example, or you go to a biomarker direct therapy. And I don't think we have a clear answer. That will be a nice clinical trial. But, to your point, I talk to many colleagues in the community here over Seattle, and they tell me they're used to the target approach. It makes sense to them, right? Even in lung cancer. So they may go for a biomarker-based approach, or although I know we debate in conferences and some people, follow your approach, biomarker-directed approach with trastuzumab deruxtecan or dafitinib, which one, it's hard to tell if you have both targets present, or platinum gemcitabine. I think the jury is still out there. Your approach is reasonable, and it depends also on toxicity profile of the drugs and patient preference. And you alluded to nicely, Ben, about PO versus IV. Dafitinib is in the game, and of course, access to ophthalmologists or optometrists that is needed for their dafitinib drug, nutritionists, discharge from the cancer center, patient preferences, all of those, familiarity of the provider also is relevant. So I think platinum gem or dafitinib or deruxtecan, depending on the presence of the biomarker, are reasonable choices. I would definitely keep taxane for the last line later on.
Yes.
For sure. As you pointed out nicely, we now have the Thor cohort 1 that dafitinib is superior to docetaxel for those with FGFR3 activating mutation or fusion. Sacituzumab govitecan, it's a big question, Ben. It's still listed in the NCCN guidelines. I use it case by case as a later line of therapy. After I exhaust life prolonging therapies. Of course, trials can be important, but right, if I use it sacituzumab govitecan, I do it with primary prophylaxis with growth factor, GCSF upfront from cycle 1, and we have a phase 3 trial ongoing in the cooperative groups and CTN, the ECOCACN 8231, which is testing the combo of sacituzumab govitecan with GCSF primary prophylaxis plus pembro versus platinum gemcitabine or docetaxel, depending on the prior therapies, asking the checkpoint inhibitory challenge question, which is, I think it's relevant, and we have tried to answer it in kidney cancer, but not in urothelial. So hopefully we can get indirectly some answers through that trial.
Yeah, I think I'll further that, right? I think that's a great point. It's a great trial. And when I give SG, I'm often in that setting, and I have given it a few times over the last 6 months. I also sometimes start at 7.5 and give growth factor support just to prevent all those neutropenic fevers. Clearly a very palliative setting, but it wouldn't be crazy to continue 10. That was potentially one of the big reasons that drug and trial may have failed. And then the other thing is, as you mentioned, clinical trials, right? I mean, if you're progressing, your patient's progressing on enfortumab vedotin and pembrolizumab, and they don't have any of these other biomarkers, and they're willing to travel, they should probably all be referred to either a large academic center with clinical trial options or one of those, large community centers with clinical trial options, because realistically, that is going to be the best thing for that patient.
Excellent point, Ben. I share your enthusiasm about the importance and the value of clinical trials. That's how we make progress. And you and me are really, really passionate about it. And you're doing such a great job in your institution leading those efforts. So definitely a big plug for clinical trials as a vehicle for progress and providing access to patients to promising therapies. And with that optimistic note, and again, reminding everybody again the importance of tumor genomic testing and HER2 IHC with casting scoring at the time of diagnosis of advanced disease, we can thank the audience. I think this is really amazing discussion here. Ben, thank you for your time, and I always love to work with you.
Yeah, no, thank you. This was fun. It's always a good time.
Thank you so. Okay, time flies and we have no more time for questions at this point, but it's very, very important to have this dialogue, and I want to say a big thank you to all of you for joining us. Importantly, I'm just going to bring up on screen again our QR code for today's session. You will need to scan this to claim your CME certificate, which is completely free. I will also place the link in the chat box. I hope you have found today's session very helpful and interesting. It has been a real great pleasure to host you. If you have enjoyed this session, please be sure to check out our other resources on methodologeducation.com, where you can claim CME credit for participating in all our free CME programs. Thank you so much again for joining us.